Dr. Iyengar, the next two. Are there locations where Mets are better targeted with radiation? And then how do you measure the success of radiation?
I'm going to be biased, and I'll say that if we can deliver appropriate dose, we can control disease in any part of the body, but that dose is limited by the normal tissues that surround that site. I would say for oligometastatic lung and the patterns of failure, we do a good job of managing control with SBRT when we need to treat in an oligometastatic fashion. But I will not, downplay toxicity. Toxicity is a very significant issue. It's going to become even more so as more patients receive immunotherapy, as they receive ADCs and bispecifics, and as we start thinking about patients longitudinally living longer, having chronic disease, and we having to come back repeatedly in a sequential fashion to radiate their lungs for new sites of disease. And so, I think the most complicated, scenarios are pneumonitis. Even though, I think we have a handle on it, there are some patients that develop a refractory pneumonitis. We have to have them on long-term steroids of high doses. And even then, their baselines are never the same again. So I think pneumonitis is a very significant toxicity. Esophagitis is something we could manage and we're careful about. Any injuries, neurologic injuries are something not to be taken lightly. The brachial plexus is a set of nerves that come from the neck down the arms, and we often are having to radiate and re-irradiate areas in the neck. And even looking at other nerve areas. So there are side effects, but as long as we use our appropriate thresholds and approaches, we can limit the toxicity. But I would say pneumonitis going forward could become the type of toxicity that limits patients receiving further systemic or local therapies. And to me, that's the most crucial thing to kind of control and manage.